Today we will just discuss about asthma. Who will tell what is asthma?
Hyperreactivity
What is
of
hyperreactivity?
airways.
Hyperreactivity of airways is asthma.
Inflammatory process
Inflammatory process is asthma.
in which there is dyspnea, wheeze, and tachycardia.
This is not a definition of asthma, and it is not matter of definition. It is matter of components. What is the difference between asthma and COPD?
Sir, obstructive and restrictive.
No, this is not also not the answer. What do you mean by obstructive?
Asthma is reversible and COPD is irreversible.
Just a second. Who will answer? Mozamar, please answer.
Yes, sir. Asthma is reversible obstruction and COPD is irreversible obstruction.
Irreversible. Okay, so what Dr. Humera was telling was correct, but was not the organized answer. Okay, so it is a reactive airway disease resulting from any tendency. Okay, what are different types of asthma? Yes, Munazza, you want to tell?
So different types are acute and chronic.
Okay, this will be presentation. This is not type.
Intrinsic and extrinsic.
What do you mean by intrinsic and extrinsic?
Allergen is inside the body, that is intrinsic. And when it is in the air, it is extrinsic due to some allergen.
How allergen will be inside the body? Okay, so we will just try to have a basic concept. Actually, when we are talking about asthma, there is reactive airway disease, okay, which is resulting in narrowing of airway. Okay, so there is one system which is sympathetic system, and the receptor here are beta 2 mediated smooth muscle relaxation. This is one thing, and the other thing is parasympathetic, which is vagal mediated, and it is through muscarinic receptors. Okay, so there is increase in secretions, increase in bronchomotor tone. Okay, so whatever will be the reason, it will be ending at either vagal or there will be the opposite is beta 2 mediated bronchodilation. Okay, so that's why if there is one is allergic and one is non-allergic. Okay, so what you were saying, intrinsic and extrinsic, what was it? Yes, can anyone explain this extrinsic and intrinsic asthma? Atik bhai, what is intrinsic and extrinsic asthma?
Sorry, extrinsic asthma is the asthma that is due to some allergy. Sir, that is due to some allergy.
Okay.
And extrinsic asthma, extrinsic asthma, there is childhood asthma topic, and there is a topic individual having allergy like IgE antibodies, pollen, house dust, animal dander, or fungal, or any allergens. Sir, that is run in his family, sir.
Okay.
And sir, Another thing is the sir. Another thing is the uh, uh, intrinsic asthma,
Okay.
chronic or non-atopic intrinsic. This only internally it behaves. It is not due to external allergen. It is only due to some intrinsic behavior, sir.
Okay.
I don't know the etiology of this one, but it is sometimes it is in the body, not due to some outside the allergen like pollen dust. It is the inside of the. It is chronic or some sympathetic stimulation in the body.
Okay. And intrinsic, what about where will you categorize vasomotor?
It was a motor, sir. It is in intrinsic asthma, sir.
Intrinsic. Okay. So because of extremes of emotions. Okay.
Extreme of emotion, sir.
And it is also related to cold weather, early morning. Okay.
Sir.
Anyways, so because today our focus is towards acute. So like when there is asthma, for example, if you just now concentrate on acute attack. Okay. So acute attack will be either it will be life threatening. Okay. And or it will, the other one is called as acute severe. Okay. So if you just try to chalk out what are the challenges or what are the problems which you can face during a patient having attack.
Sir, sorry, couldn't understand your question, sir.
I'll repeat.
Again?
Just give me a second. Just give me a second. My question is that basically in asthma, when there is attack, there is one is airway obstruction. Okay, so patient is dyspneic. Okay, so when patient is dyspneic, there are all the problems related to respiratory distress. Okay, so one thing is respiratory distress. Okay, this is one thing. What other things patient will have? There is sympathetic stimulation.
Sir, the changes in sir,
Tachycardia.
Sympathetic tachycardic. The patient may be tachycardic, and sir, it depends upon the history, examination, and sir, inability to complete sentence, respiratory rate, and sir, peak expelled flow rate, sir.
No, that is I'm just
Rate.
actually I'm just trying to have your brainstorming that when you are dealing a patient with asthma, what can be one problem will be related to respiratory distress. Okay. Okay. So other problems which will be there because of sympathetic stimulation. Okay. So there is a patient that will be leading to a number of problems, including for example, if it is so much severe, even behavioral changes. Okay.
So, sir, three systems are involved in asthma. One is respiratory system, another is cardiovascular system, and the third one is the central nervous system, sir.
Central
CNS.
nervous. Okay. So like and some problems you will be inviting by the treatment. Okay. So when you are giving the treatment, either you are giving beta 2 agonist, which are causing more tachycardia, or they can cause arrhythmias, or what will be the third thing? Hypokalemia.
Hypokalemia, sir. Hypokalemia.
Okay. So there may be arrhythmias.
Hyperglycemia, sir. Sir, hyperglycemia, arrhythmia, tremors, hyperglycemia, and sir, another thing is lactic acidosis. Maybe sometime.
But there is a funny thing that when, for example, if patient is having hypoxia-mediated tachycardia, and you give beta agonist, and actually the hypoxia is treated, so actually tachycardia will be reversed. This is also a paradoxical sort of effect, which is definitely seen. Okay. So,
sir, in life-threatening asthma, same thing happens. There will be hypotension with bradycardia.
yes. No, that is sign of impending respiratory failure. Okay. That is something, as I'm
Sir.
just telling you, that if, for example, hypoxia is leading to tachycardia, okay. So if you are treating the hypoxia, actually the tachycardia will be reduced. That's what I'm saying. Okay. So this is one thing. Then another thing will be that if patient has some comorbidities, this asthmatic attack can even lead to MI. Okay, this asthmatic attack can lead to even like, because there is air trapping, and even maybe it may lead to pneumothorax. So these are the things which can occur simultaneously. So whenever you are
Sir, can I say one thing?
yes,
Sir,
yes,
in asthma, there is also always this MCQs coming that if you are giving you are intubating the patient, and it is the patient is carbon dioxide is very high and unable to complete sentences, and sir, pending respiratory failure, then you have to intubate the patient. Sir, on the basis of EBGs as well, sir. When you are intubating the asthmatic patient, you may not ventilate the patient. So when and in the MCQ, the MCQ will be like this, that you will do another maneuvers, or you will extubate the patient and then again try. So the answer is the you will remove the tube and again intubate, and under the vision. And sir, again, if it is not coming along with the senior help, then you can see through your naked eyes the tube that it is gone in the vocal cord, and then you will gently ventilate the patient, because so many times it is occurs that you have intubated the patient very rightly, but the patient is not behaving, that it is it occurs that it is in the esophagus. So first of all, you will for the first impression you will take it out, and on the second intubation, individual along with the senior help, you will just gently ventilate the patient if it is ventilating is difficult as well, sir.
Actually, if you are trying to say, but I understand that if there is severe bronchospasm, okay,
Brittle asthma, sir, acute brittle asthma.
yes, so you are not able to ventilate. Okay, so of course there will be entitled CO2. Anyways, I don't know what stem they are telling you.
Sir, I have so many times I have seen the patient of asthma. If I once I have debated, it occurs that the tube is not in the vocal cords. I have removed it,
No,
but
actually,
again
sorry, I tell you something. I just correcting you that because of exam point of view, or even in like any international standards, there must be end-tidal. Okay, so if you are inside the airway, even if you are not able to ventilate, there will be some end-tidal. Okay, the graph will be different, but if you are inside the airway, there will be end-tidal. The pattern will be showing obstruction. That is correct. But it is not possible that the patient tube is inside the airway, and like you. Anyways, I hope you understand my point of view. So this is
sir, my point was that, sir, we have tried to intubate the patient, and we just done on the ambo bag. The ventilator was not taking that patient because it desaturated immediately, sir.
the reason
After
is
nebulizing
bronchospasm.
multiple.
The reason is
No, sir,
bronchospasm.
no, sir. It is not bronchus. We have done CPR, and then the patient came into ITC, and we have intubated the patient, and it was difficult to ventilate as well for 1 or 2 hours. Then we have done every maneuvers, And sir, I was talking in that scenario as well, sir. Sir, in asthma, the ventilation and ventilating on the machine is difficult. On ventilating on the even bamboo bag is difficult, sir. Okay, sir. I got your point, sir.
So just a second. So how will you assess the severity of asthma? How to assess the severity of asthma?
Sir, we
Yes.
can assess the through V's, sir, on the history examination and investigation, and then in history we can see the sir, the from the patient relative or patient, because the patient may be not able to convey give the history, and it depends upon the previous admission and speed of the onset of the asthma, and about the current treatment, if she or he is taking steroid. And another one is the has he or she, the patient, has been in required any artificial ventilation before. And there is
Actually,
three criteria for
actually
sir,
answer to
asthma.
this question is a little bit different. Okay. The
Okay, sir.
one point is that you will be looking at the clinical sign and symptoms. The question is that how will you assess the severity of asthma? The severity of asthma is on the basis of the patient's clinical sign symptoms, patient respiratory rate, patient pattern of breathing, any signs of obstruction. Okay, this is as you can say over here. So these are all, you see, respiratory rate, body position, use of accessory muscles, V's, heart rate, pulsus paradoxus if it is there. So this is one thing. And the other thing which we are using is peak expiratory flow rate. Okay. So we put the severity on the basis of peak expiratory flow rate. What is that one? What is peak expiratory flow rate? It's just actually it's a spirometry. Okay. But you are doing it as a bedside, and it is telling you the what is it, what is its interpretation?
Sir, if it is the if it is between 30 to 30 33 to 50, and is acute severe asthma. It is, if it is less than 33, then it is the life-threatening asthma. If it is unable to perform sentence, then it is unable to perform the peak expiratory rate, then it is near fatal.
Yes, actually, but like it is the what it is telling. It is telling the peak it is telling the this FE1. Okay.
FE1 in 1 second, sir.
Yes. So if it is more than 50, then it seems to be normal. If it is 50
And
to
if it is more than 50, it is mild, sir.
mild, yes, more if it is between 33 to 50, it is moderate, and if it is less than 33, in some books it will be written 30, in some books it will be written 33. Okay. So that will be, yes.
If it is less than 33, it is a left threatening, and it is if unable to perform the peak expiratory rate, then it is near fatal.
No, if it is silent chest, it is near fatal. Okay. If it is patient is unable to complete the sentence in one breath, it is acute severe asthma. Because in whenever this MCQ will come, they will be telling you either silent chest with cyanosis, or they will be telling you this thing: patient is unable to complete one sentence. This is always,
Sir,
I mean,
sir, excuse me, sir, if the patient is having wheeze, the patient is alert, having wheeze, but cannot complete the sentence, and the respiratory rate is more than 25, and the peak PaO2, small AO2 is more than 8 kPa, and peak expiratory flow rate is between 30 to 50%, then it is acute severe asthma. That is written in Julian, sir, if you can
Yeah,
see
that
it.
is what I'm showing you. Okay, in the screen it is you can see it. So it is
Okay.
acute severe asthma. Okay,
Acute severe asthma.
and if
And
it
the
is
most,
silent test,
if wheeze is present, if sir only wheeze is
another
present, wheeze is
another important thing is that if you do ABGs, you will in what will be the ABGs finding here in acute severe asthma?
sir, the PaSO2 will be less,
Low.
and
Okay,
PaO2 will be
PaSO2 will
more
be
than
low.
8 kPa.
So this is also a sign of if they will be giving you a data in the MCQ, they will be telling you
Cyanosis.
they will be
Madam, so
telling
there will be
you,
no cyanosis in first.
please let me finish. If you are, they will be asking, giving you the scenario, the PaCO2 will be normal or increasing. If it is even slightly increased in a patient with asthma, it will be a sign of impending failure, like patient is about to collapse. So this is the MCQ which they will be asking you. Try to, because in Pakistani exam, they will be asking you in millimeter of mercury. This is British system, the SI unit here, they will be writing in kPa. Try to, because I don't think so in Pakistani exam, they will be writing kPa. Usually they will be writing a millimeter of mercury. Okay. So this is something on which they will make a question. So you should be just
So excuse me, the second one is if the in exam there will come like silent chest or somnolence with the single word and the peak expiratory flow rate less than 33, or PaO2 less than 8 kPa, or normal PaCO2, then it is, or respiratory less than 10, then it is a life-threatening asthma.
respiratory
And if
rate
the
less
patient
than 10 is respiratory rate is not criteria in that one, Atik bhai. Because usually it will
okay, sir.
not be respiratory rate
And
less than 10. Respiratory rate will be following when patient is going in failure.
okay,
This is
and sir, the last one, near fatal asthma, the patient is unresponsive, the patient chest is completely silent, and consciousness in the consciousness, and the patient is unresponsive, and the PaO2 is less than 8 kPa, and so now the PaCO2 is more than 6 kPa. This means that there is respiratory failure. Then it is a life-threatening asthma. Sorry, near fatal asthma.
Atik bhai, near fatal and life threatening is almost the same. Near fatal is, or you can say another superlative degree which is written in some of the books, but in majority books it's not written. Okay. So, but
Sir, life-threatening asthma, life-threatening asthma plus feeble respiratory rate plus bradycardia and plus hypotension with complete everything none is called as a near fatal asthma.
okay, what will be the finding in ECG? In asthma, what finding you can have?
No idea about the ECG.
No, there will be tachycardia. There will be there can be
Tachycardia and ST elevation.
atrial fibrillation.
Arrhythmias.
In which one?
In acute severe asthma. See, there may be
So
people there.
tachycardia, ST elevation.
Why there will be
arrhythmias.
ST elevation? Just tell me. Just explain.
Ischemia, sir. There will be ischemia of heart.
Ischemia shows elevation or depression.
Depression.
Thank you very
Sir,
much.
coronary perfusion is impaired.
So thank you. That's what actually this is non-specific. The ECG finding in there is no specific finding in asthma. This patient can have atrial fibrillation. This patient can have like tachycardia. This patient can have even SVT. This patient can have any arrhythmias. And if, for example, there is involvement of right side of heart, then there will be this P pulmonale and right axis deviation or any finding like that. Okay, X-ray. Usually chest X-ray of a asthma patient without in attack without attack will be normal. Okay, if there is any like infection, signs of infection may be there, but usually this occurs in case of COPD. Okay, so it may be normal or it may be only showing hyperinflation. What will be the differential diagnosis of increased airway pressure under anesthesia?
Sir, couldn't got. Sir, you want to say that in intraoperatively or
Intraoperatively, raised.
Aspiration,
Sir, intraoperatively,
pneumonitis.
there if there is a high peak expiratory pressure, a high peak expiratory pressure, then you will see in entitled carbon dioxide a fin-like structure, shark fin-like appearance, and the duty will be like from circuit can be kinked tube, or there may be inadequate anesthesia, endobrachial intubation. There may be pneumothorax, and persistent coughing or straining. Tongue bite can occur, and tube may be blocked by sputum or asthma, bronchospasm. And sir, but there is all Sir Liaquat has told us about the dope test. Dope test mean there is the disconnection or obstruction, pneumothorax, and equipment failure. And you will take you will disconnect the patient, and you will do embo bag. If it is the patient is then you can exclude so many diagnoses in that.
Okay, and anyways, there will be first of all during anesthesia you will be looking at inadequate anesthesia. Okay, first of all you will try to see if patient is maybe patient may be fighting. Okay, so you can see whether like a patient needs neuromuscular blocking agents or muscle relaxant or things like that. Okay, and then you can as you are telling, you can make it 100% oxygen, and you can ventilate, manual ventilation, either with ambu bag or with manual ventilation. It will tell you a lot of information. Then you can do some suction. Okay, then you can because then you will be finding the reason for it. And if it is associated, it is like if it is also associated with the this one this hemodynamic instability. Okay, instability, like patient is also having this bronchospasm, raised airway pressure with the cardiovascular collapse. So it may be, the reason may be pulmonary embolism. Okay, so it may be a early sign of pulmonary embolism. So you just have to go step by step. Okay. Okay, so there may be some anaphylaxis. Anaphylaxis may be one of the reason. There may be like secretions or things, tube kinking. Okay, so how will you treat it? Like what are different maneuvers you can do in acute severe asthma? Beta 2 agonist.
So, steroids, anticholinergics,
So first of all, sir,
magnesium,
first of all, we will have
oxygen.
oxygen.
Please, if two people will speak out, nobody will be understanding. Let her speak or let him speak. Yes, anticholinergic, beta 2 agonist. What else? Yes, Atik bhai.
Sir, first of all, we will if the patient is having patient with the bronchospasm intraoperatively. First of all, we will increase the oxygen, and we will disconnect. Then we will increase the oxygen. We will prop up the patient, and then we will give a puff of the at least 8 to 12 puff of the ipratropium bromide and Ventolin puffs. And if the patient is not behaving, then we can increase the inhalation sevoflurane in that. And if it again, then we can again give the nebulization again. We will start nebulizing and nebulizing. If it doesn't work, then we will go to the intravenous beta agonist, sir. And then of course magnesium sulfate, steroids, and anticholinergics. And then of course, if it's not working, then aminophylline. And we can, in that time, we can also work for the ketamine and inhalation agents, as I told. And if it
Is
is still not working,
aminophylline
then it
is still written in the guidelines?
I don't, sir. If all maneuvers are failed, then we can give aminophylline.
I don't
But
think
it is
so.
still
Aminophylline
arrhythmogenic
is
and
obsolete. Aminophylline is obsolete. Okay. Aminophylline is obsolete. Yes, Mausama, what will be the mechanism of aminophylline? Why it was being used?
So it has bronchodilatory property. I don't know, sir. I'm
What
not
sort
sure.
of broncho? How it does bronchodilation?
Phosphodiesterase.
Yes, yes. Dr. Humera, please, when someone is answering, please don't interrupt. Okay. You got the chance. Yes, Mausama, what will be the mechanism of action? One is phosphodiesterase inhibitor. What else? There is one more thing. Now you tell Dr. Humera, do you know about it? What is the role? And there is another role of.
Sir, I knew only this phosphodiesterase.
So thank you very much.
PDE1.
I expect more than this. This everyone knows. Anyone, please. There is another role for which it was being used. Yes, Atik bhai.
Diaphragmatic stimulation.
Thank you very much. Who spoke this thing? Zaigam.
Yes, sir.
So this is the answer. Okay, but it is now not being used because it is associated with more problems than advantages. Okay. I think this is old guideline. I don't think so. This is new one because aminophylline is associated with arrhythmias than anything else. Anyways, if it is written, it's fine because as far as I remember, it is associated more of the complications than advantages. So if you are failed with everything, then you can go. Will there be any role of helium? Yes, Atik bhai. Will there be
there
a role
is sir, conventional, sir, there is also, we have been asked in Viva that there is conventional, non-conventional.
Okay.
The non-conventional method, we can use adrenaline, we can use ketamine, and we can use helium because it reduces the work of breathing because of the decreasing density.
Tell me one thing, when there is bronchospasm, is it related to upper airway or lower airway?
Bronchospasm is a lower airway, sir.
Lower airway. So there is no role of helium. Rather, helium will create a problem that you are not able to give high FiO2.
No, sir, excuse me, sir.
I understand your point that helium is reducing the density. Okay. So it will be decreasing the work of breathing, and this is related to upper airway obstruction, not lower airway obstruction.
Sir, the helium is not only for the big vessels, it can also the small vessel as well, sir. It will decrease the turbulent flow. Maybe, sir, I may be wrong.
Let us confirm it because as far as my concept is that helium will have effect in upper airway. Okay. This reduces the work of breathing by reducing gas density and therefore turbulent flow. But you see, FiO2 limited. Okay. So if they are asking you, you should tell only at the end, not in the
Okay.
start.
It's a non-conventional, sir. I already told.
Okay. Okay. So what will be the role of magnesium?
Sir, in the magnesium, it has three purposes. Sir, it can antagonize the calcium by affecting the bronchial smooth muscle, and it decrease the acetylcholine release of all the neuromuscular junction, and it increase the sensitivity of beta agonists.
Yes. So actually, it is membrane stabilizer. It is working
Membrane
as a
stabilizer.
membrane stabilizer, and it is working as a smooth muscle relaxant. Okay. So that will be the role. So that's what I was telling you about aminophylline and acute asthma. The use of intravenous aminophylline does not result in any additional bronchodilation compared with standard care with beta agonist, and the frequency of adverse effects was higher. That's what actually I only remember this thing. Okay,
Sir,
so
but the magnesium dose is different. In this one, this is 2 gram over 20 minutes. Then 1 to 2 gram, 1 or 2 gram in IV infusion till the asthma is over. Asthma attack is over, sir.
okay, so how will you see now, Mozama, you will answer. How will you say that patient is responding to the treatment, asthma patient? How will you follow up the response to treatment?
Sir, respiratory rate will be reduced.
Very
Patient
good.
saturation will improve. ABGs at ABGs, if there is a CO2 retention, it will be patient reduced. Patient, if there is altered sensorium or CNS symptom, they will be reversed.
You are not telling the
Antiviral-
important thing. You are telling the things which are not wrong but not correct. We are looking at now, we had just discussed at how to assess the severity. So that is the same thing will be improving.
symptom
PFR.
symptom
PFR.
peak expiratory flow
Peak
rate.
expiratory flow rate will improve. Okay.
Yes, sir.
So because CO2 is already, if CO2 is going high in asthmatic patient, you are gone. Patient is gone and you are also gone. Okay. So
Yes, sir.
PO2, you can say PO2 will improve. The overall condition of the patient, respiratory distress will be improved. Respiratory rate is decreased. Work of breathing is decreased. Okay. Overall sympathetic response is decreased. And then you quantifying, you will be saying PFR. Okay. So then you will decide whether to admit the patient, whether to send the patient to ICU, because they ask this question in that way. So I think we will just summarize that, like asthma, we just say that it's reversible. So
Sir, can I add something in that Madam Mosma have told?
yes.
Sir, as you told, sir, you will look for PFR and ABGs, especially ABGs, sir, you will look at. The ABG acceptable to us will be PaO2 more than 60 mmHg, and sir, the PaCO2 should be less than 60 mmHg. PaO2 should be more than 60 mmHg, and pH should be more than 7.25, and on saturation should be more than 90, on FiO2 less than 40%, sir.
Okay. Okay.
And then all you have already told everything.
Yeah, actually, remember one thing in asthma, pH is not that much effective. We are mixing because we are specifically discussing about asthma. So there is difference between asthma and COPD. Okay, these things usually in asthmatic attack, because it's a reversible condition. So things will be reversed, and you are seeing the reversibility on the basis of PFR and the clinical sign symptom. Okay. So usually when they ask what is asthma, you should be telling it's a reversible airway obstruction. You should not start, because there is no other difference. COPD is also hyperactive airway disease, and there is destruction of airway, and there is not fully reversible. Asthma is fully reversible. So that is the difference. So do we just, in this our discussion, We just discussed about what are different types of asthma, what are different, and just last thing, that some of the medications which are for maintenance. So for maintenance are steroid, for maintenance are leukotriene antagonist, for maintenance is this mast cell stabilizer, sodium chlomolin, like what sodium, what is the name? I always mix the pronunciation. Sodium chromolin, something like that. Okay. And leukotriene antagonist might occur. And if there is some specific allergy, you will be treating that allergy. So this is the long-term management: acute attack, steroids, beta-2 agonist, ipratropium. If it is not working, then as we discussed, that there is a role of magnesium sulfate, lidocaine, even ketamine, aminophylline, a controversial thing, people use it, and helium, and rest of the things which we said that because it will be only be used if the first line things are failing. Okay. So thank you very much. Inshallah, we will discuss.
Sir, excuse me, I want to
next
add
topic,
something.
cervical injury.
Sir, I want to add something. Sir,
Yes.
hello.
Yes.
Sir, I
Yes.
want to add. Sir, if we are inducing the inducting the asthmatic patient for surgery, then there are 3 risk factors we should be kept in mind. Sir, first is risk of perotrauma or pneumothorax while intubating. Second is the air trapping and intrinsic PEEP, and the third one is the PEEP can worsen the air trapping, and air trapping can go in hyperinflation. Then it can cause a decrease venous return. Then it will decrease the cardiac output, and then it will cause the hypotension. So some drugs we should be avoiding. We should avoid the histamine releasing drugs. And should be sir, we should avoid the drugs that can cause bronchospasm. And we should keep the sir, you haven't told us about the asthmatic ventilative strategies. It is
Yeah, actually this was not the topic of discussion today. I just touched it because my topic actually was only acute severe asthma. Okay.
Okay, sir. Okay, but sir,
There are so many other
should
things.
I tell the about the ventilators? Is 4 to 5 points, then it will be finished, sir. First of all, sir, we have to FO2 should be more than 90. When you are putting the patient of asthma, acute severe asthma, on the ventilator setting and admitting in ICU, then you should keep the tidal volume low, 6 to 8 ml per kg, and then you will keep the respiratory rate between 10 to 12, and you will increase the, sir, this is a very important point, you will increase the expiratory time 1 to 4 to avoid air trapping, and you will keep the minimal PEEP, that is 5 centimeter of water, and you will keep the peak peak airway pressure less than 30, and the PSV mode will be the best mode, sir. Thank you very much, sir.
Okay, so inshallah tomorrow we will do cervical injury. Okay.
Okay, sir. Okay.
Bye. Assalamu alaikum.
Sir, any role of adrenaline?
There is a role of adrenaline.
Madam,
Atiq bhai told beta, it is beta, you will be giving it in a low dose, and you are trying to get the beta-2 mediated bronchodilation.
Ji, sir. Thank you.